Our group looked at adverse childhood experiences and social support networks and interventions. Our group members include Sherry Martinez, Julie Diaz, Satai Zhu, and Nagar Bagari.
In this video, we'll cover these learning objectives. We'll first define ACEs and its prevalence. We'll then move into prevention and look at social support networks. We'll also look at physical and mental health outcomes. And lastly, we'll provide a toolbox for practicing clinicians. Let's go over defining adverse childhood experiences and what that can look like. Adverse childhood experiences, or ACEs, are traumatic events or potentially traumatic events that a child or adolescent experiences before they reach 18 years old. A child or adolescent may experience ACEs in fragments or throughout their entire childhood. This encompasses early childhood, middle childhood, early adolescence, middle adolescence, and late adolescence. The 6-point identity consolidation is when a child is able to engage in this process of developing a positive sense of self, which may occur despite the exposure of ACEs. Adverse childhood experiences may look different for everyone. For some individuals, ACEs not only consists of experiencing one or a series of traumatic events, but also the effect of a child's environment, housing, and/or food instability. Some examples of ACEs include abuse, whether that be physical, emotional, and/or sexual, neglect, whether physical and/or emotional, and household dysfunction, such as a personal or family mental illness, incarcerated relative, parent treated violently, substance abuse, and divorce. Out of all these potential ACEs a child or adolescent may experience, the CDC reports that the most common ACEs are emotional abuse, 61.5%, physical abuse, 31.8%, and household poor mental health, 28.4%. Prevalence has also been found to differ by age. Older adolescents around 17 years old have been found to more commonly report experiencing 4 or more ACEs among all children and adolescents ages 0 to 18 years old. The same study by the CDC reports that 3 out of 4 high school students report experiencing 1 or more ACEs, and 1 out of 5 high school students report experiencing 4 or more ACEs.
Okay, let's take a look at the prevention and social support networks. The prevention happens when we reduce risk factors that lead to ACEs and increase protective factors like safety, connection, belonging, and resilience. We can think about prevention across 3 systems, like schools, families, and social networks. School and social connection can be one of the most powerful protective factors for youth. Studies show that the school-based intervention is designed to help youth deal with stress, adverse life events, and suicidal thoughts by improving coping skills, and school connectedness can reduce severe suicide ideation and suicide attempt for teenagers. Connecting them to the peers and social connections is also important, like after-school programs such as sports, arts, clubs, and community service help kids build identity and belonging. Connected youth are more resilient. They are less likely to experience isolation and depression. Prevention in families can also include parenting programs that teach positive discipline, the emotional attunement, and stress management. Early interventions such as visiting programs that support new parents and identify family stress early, and encouraging parents to listen, validate, and create emotional safety for their children. Preventing ACEs isn't just talking about avoiding harm, it's more about building resilience and creating the positive experiences. Childhood experiences have a healing and protective effect even for children who faced adversity. Increased resilience also mitigate the adverse effect of ACEs on health outcomes and lower rates of mental and physical health problems. ACEs can be intergenerational, effective, trauma-informed, relationship-based interventions for parents that begin as early as possible may also have enduring effects on adolescents across emotional, cognitive, and relational aspects.
Now going into the physical and mental health outcomes with adverse childhood experiences. This slide shows how the number of ACEs relates to health outcomes. The more ACEs someone has, the higher their risk for health problems later in life. Babies might start off with things like growth delay, cognitive delay, sleep disruption, and as they get older, that can turn into issues like asthma, infection, learning disabilities, and behavioral problems. In teens and adults, we could see obesity, bullying, teen pregnancy, violence, and substance use. Every additional ACE increases the chances of poor health outcomes. Going into the physical health, specifically diabetes, ACEs just doesn't affect mental health, but they also impact physical health. Even one ACE raises the risk for diabetes by about 22%, and having 4 more bumps it up to about 44%. That's because chronic stress from ACEs can cause inflammation and insulin resistance, which makes diabetes more likely over time. ACEs are also strongly linked to mental health issues like depression, anxiety, PTSD, and substance use. People who have experienced 4 or more ACEs are 3 to 5 times more likely to have a mental health disorder. Continuing with mental health, we see many correlations between ACEs and diagnoses. When it comes to depression, we see a clear pattern. Every additional ACE increases the likelihood of depressive symptoms by about 25%. Borderline personality disorder is also strongly connected to early maltreatment. Childhood abuse is one of the strongest predictors for that. For substance misuse, research shows that adversity in childhood increases the chances of using alcohol or drugs during adolescence and adulthood. And finally, emotional maltreatment is closely linked to mental health problems in teens, including higher rates of overall psychopathology. Going into integrating interventions into practice, the first tool in our box is 3 types of assessments. These assessments are questionnaires typically asked to children, and depending on the amount of yes responses will determine the severity of ACEs. Assessments listed here cover topics such as trauma, abuse, negative and stressful events, and resilience. This assessment is not used as a diagnostic tool, but is used to help guide us on how to proceed with treatment. Next, this is a pathway referral. It will help you determine which path of care the client needs based on their needs. You need to first determine if the child is currently at risk of any adverse experience, and that will determine your route of treatment. If the child's response is yes to acute risk, then you need to proceed with mandatory reporting and crisis protocol. If the child response is no to acute risk, then you will carry on with immediate support and follow up with the appropriate level of care or other services needed, such as mental health, substance use, community resources, and school-based resources.
Our group looked at interventions that utilize trauma-informed care and skill building to build positive relationships. The goal of utilizing these interventions is to mitigate poor health outcomes of ACEs through social support networks. In a study conducted by Lieberman et al., they examined the durability of improvement in child and maternal symptoms 6 months after termination of child-parent psychotherapy, CPP. CPP is a relationship-based treatment that's proven to decrease behavior problems and symptoms of post-traumatic stress disorder among both children and their mothers. The child-parent relationship is utilized to improve the child's emotional, cognitive, and social functioning through a focus on safety, affect regulation, the joint construction of a trauma narrative, and engagement in developmentally appropriate goals and activities. Researchers used the Child Behavior Checklist for preschoolers and the SCL-90R for mothers. After 6 months, children in the CPP group showed significantly fewer behavior problems than the control group. Mothers in the CPP group also had lower global symptom severity compared to control mothers at the 6-month follow-up. The study affirms that social support networks not only serve as a protective factor for individuals who've experienced ACEs, but that interventions such as CPP improve children's behavior problems and maternal symptoms. In addition to social support interventions and parental relationships, interventions for foster youth also demonstrated positive outcomes. In a study conducted by Tossing et al., the researchers examined the impact of a mentoring and skills group intervention for pre-adolescent children in foster care. Youth in foster care have higher rates of adverse childhood experiences and often experience many placement changes, as well as are placed into residential treatment centers. The 9-month intervention included manualized skill group and a one-on-one mentoring. The FHF curriculum blended CBT-based activities with process-oriented work covering topics like emotion recognition, perspective taking, problem solving, anger management, cultural identity, change and loss, healthy relationships, peer pressure, abuse, prevention, and future orientation. The mentoring component, on the other hand, provided one-on-one mentoring for the children. The mentors created empowering relationships with the children, advocated for appropriate services, helped the children generalize skills learned in group, and engaged children in a range of extracurricular, educational, social, cultural, recreational activities, as well as help promote attitudes to foster positive future orientation. The intervention group was 71% less likely to have a new RTC placement over 18 months. In the non-relative foster care subsample, youth had 44% fewer placement changes, were 82% less likely to enter a new RTC, and were 5 times more likely to achieve permanence 1 year after the intervention.
And that concludes our presentation. Thanks for watching.